now we're going to do pulmonology. So COPD is chronic obstructive pulmonary disease, which is seen in chronic smokers and sometimes alpha-1 antitrypsin deficiency. COPD has two different variations. One is chronic bronchitis and the other is emphysema. So chronic bronchitis has excess mucus production from mucus gland hypertrophy, and this narrows the airways, whereas emphysema is where you have destruction of the alveoli. So on auscultation of the lungs, you will hear hyperresonance on percussion. Because why? Because the alveoli are all destroyed, so this increases the amount of air in the lungs. You have decreased breath sounds because it's an obstructive lung disease, so it's harder for them to exhale. You'll also hear crackles. Why? Because people with chronic bronchitis will have excess mucus production, and that will produce crackles. Also in the alveoli that are blown out, they will also have excess mucus in there, which causes crackles. And then wheezes is due to airway narrowing from the mucus gland hypertrophy. So only two things decrease mortality in COPD, and that's quitting smoking and home oxygen. And then COPD, the stages are based on FEV1 percentage. So greater than 80% is mild, moderate is 50 to 80, severe is 30 to 50, and very severe is less than 30. And depending on each stage, you have different types of treatments. So for 80 and above, it's albuterol. For 50 to 80, you want to add ipratropium. From 30 to 50, you want to add an inhaled steroid. And for less than 30, that's when you add long-term oxygen. Remember, there are two other indications for adding home oxygen, and that's a PaO2 of less than 55 or an oxygen saturation of less than 88. And then people who have COPD exacerbation, the key I want you to look for here is anyone with COPD who has a change in sputum production, whether it's increased sputum or a change in color. That's an exacerbation. You want to do a chest x-ray to rule out possible pneumonia. But if it's an exacerbation, you add IV steroids and an antibiotic such as fluoroquinolone or azithromycin. And you also give non-invasive positive pressure ventilation, but you don't want to exceed 93% because this can cause shunting. COPD with pneumonia, this is treated with Zosyn or cefepime. Zosyn is also known as piperacillin and tazobactam. But the thing is, I want you to remember, a COPD patient with pneumonia, the most common bug is Pseudomonas. Asthma patient with normal, this is high yield. It's a question where a patient who's coming with an acute exacerbation of asthma and they're in respiratory distress, but their PCO2 is normal or elevated. What should you do next? Intubate. Why? Because a patient with asthma should be hyperventilating, so they should have respiratory alkalosis, so their CO2 should actually be low. If it's normal, that means that they're getting tired and they're not able to blow out all the PCO2. So respiratory failure is basically inevitable, so you want to intubate before that happens. So asthma, there's also 4 stages that you need to know. So there's intermittent, mild persistent, moderate persistent, and severe persistent. So mild intermittent is like less than twice a week. Mild persistent is 3 to 7 days a week. Moderate persistent is every day, and severe persistent is multiple times a day. So at each stage, you want to add a different drug. So at mild intermittent, which is less than twice a week, you can just do albuterol PRN. But then as it progresses, you want to add a low steroid, and then the next stage you want to add a medium steroid, and then the final stage you want to add a high dose inhaled steroid. You can also have acute asthma exacerbation, and in this one you want to first give albuterol, but you want to also give IV steroids and oxygen. Whereas in COPD exacerbation, you also give IV steroids and oxygen, but you also add antibiotics. Bronchiectasis is permanent dilatation of the bronchi, and loss of cilia caused by recurrent infections. And what this will cause is a lot of mucus. And so this person will be coughing out buckets and buckets of mucus every day. And cystic fibrosis is the most common cause. This is a form of obstructive lung disease because of the blown out bronchi. And you diagnose this with a high resolution CT, and you treat it with bronchodilators. Exacerbations are treated with antibiotics. Cystic fibrosis, this is autosomal recessive. All secretions are thick because the chloride transport channel doesn't work and water will follow it, so all the secretions are very thick. Remember the ages, so less than 20 is associated with Staph aureus, but above 20 is associated with Pseudomonas in terms of pneumonia. And you treat this with supplementing things such as pancreatic enzymes, vitamins D, E, A, K supplementation, and inhaled Dornase, which helps break down the secretions in the lungs. So next, I want to talk about Pancoast tumors. So Pancoast tumors is a lung cancer in the upper lobe of the lung, and this can cause different manifestations and complications. So it can cause Horner syndrome, superior vena cava syndrome, phrenic nerve palsy, recurrent laryngeal nerve palsy. Remember, superior vena cava syndrome is if you have some sort of obstruction that impairs the drainage of the veins into the SVC. So a lung tumor can do that, and it would present with edema of the face and arms. And then Horner syndrome is if you have invasion of the sympathetic ganglion, and then this would give you ptosis, meiosis, and anhidrosis. Sometimes the tumor can invade the brachial plexus, which causes weakness in the right arm. You can have phrenic nerve palsy as well, which causes one diaphragm to be higher than the other. And then recurrent laryngeal nerve palsy, which causes voice hoarseness. So those are the complications. And remember that smokers tend to have central lung tumors, and the most common ones are squamous cell carcinoma or small cell carcinoma. And remember that the squamous cell carcinoma produces PTHRP, parathyroid hormone related peptide, so that can cause hypercalcemia and hypophosphatemia with a low PTH because it's the PTHRP that's causing the hypercalcemia. And then small cell cancers are associated with SIADH, ACTH secretion, and Lambert-Eaton, which is when you have the antibodies presynaptic calcium channel receptor, which prevents the release of acetylcholine at the neuromuscular junction. Versus myasthenia gravis, Lambert-Eaton will improve with usage, whereas myasthenia gravis has weakness that worsens with usage. Adenocarcinoma is associated with non-smokers, and they're more on the peripheries. The next point is really high yield. If you have a vignette where a patient has a nodule on chest x-ray, a new nodule, what is the best next step? The best next step is to find a previous chest x-ray to compare. If it changed, then you want to do a CT after that. If you don't have any old imaging in the vignette, like to compare to, then the next step is CT. So signs of pneumothorax would be one-sided decreased breath sounds, hyperresonance, and decreased fremitus. Fremitus is the vibration from palpation. And then versus tension pneumothorax, the key here is the tracheal deviation. And tension pneumothorax will also have hypotension because of compression of the IVC. Yeah, and then remember, they're treated differently. So just a normal pneumothorax, you can treat with a chest tube, whereas tension pneumothorax, you have to do a needle thoracentesis first because it's quicker. This is more urgent right here to release the air, and then you can take your time and put in the chest tube afterwards. Interstitial lung disease, the ABCs of interstitial lung disease are asbestosis, beryllium, coal, silicosis, and sarcoidosis. And on chest x-ray, you will see reticulonodular ground glass appearances or honeycombing. Asbestosis is also associated with pleural plaques and mesothelioma. And then silicosis has the eggshell calcifications of their upper lobes. Speaking of upper lobes, there's three things that like to go for the upper lobes, and it's silicosis, TB, and aspergillus. Sarcoidosis can also produce interstitial lung disease, and remember earlier I was saying that it can cause restrictive cardiomyopathy. But for sarcoidosis, remember on chest x-ray, you'll see the bilateral hilar adenopathy. And this in sarcoidosis, all the vignettes look at the calcium. They'll always have hypercalcemia because the granulomas tend to make more calcium. And then ACE enzyme is also elevated, and you treat this with steroids. So for respiratory failure, people who have low PaO2 think of lung diseases, and people who have a high PCO2 think of hypoventilation, and that means they have difficulty getting air out. So think of like obesity hypoventilation or COPD. Whereas a low PaO2, think of like interstitial lung disease. Next, you need to know about the basics of mechanical ventilation. So there are 4 parameters, and so there's tidal volume and respiratory rate, and there's FiO2 and PEEP. And each one of them either helps manipulate PCO2 or PaO2. So in terms of PCO2, this is for ventilation. So tidal volume and respiratory rate will help alter your PCO2 levels. If you increase tidal volume, then you can exhale your PCO2 more. So increasing tidal volume will lower the PCO2 more, and increasing respiratory rate will also lower PCO2, and vice versa. And then PaO2 is an analog of oxygenation, so you can control that with FiO2 and PEEP. The higher the FiO2, the higher the PaO2. The higher the PEEP, the higher the PaO2, and vice versa. And you'll get a question where someone's on mechanical ventilation and their PCO2 might be too high out of the normal range, and they'll ask you, what should you change? And then look for either increasing tidal volume or respiratory rate. Usually the tidal volume is a better answer than respiratory rate because it can change the PCO2 more efficiently. ARDS is caused by some sort of systemic infection like pyelonephritis or like severe pancreatitis. And this is where you have increased vasodilation of the pulmonary capillaries, which causes leakage into the alveoli and then collapsing of the alveoli. And you want to treat this with high PEEP and low tidal volume. So remember, high PEEP. Pulmonary hypertension is diagnosed with pulmonary artery pressure greater than 25, and this is just something you have to memorize because a lot of times in the questions, some of the things you need to just memorize because they're not in the lab values. Another thing that you might want to memorize is like lactate is normal, is less than 1. Over 1 is considered lactic acidosis. Aspiration pneumonia, this is caused by people who are on mechanical ventilation or people who have impaired gag reflexes, such as those with dementia or seizures or alcoholics or stroke patients. And you want to first, and it'll cause right lower lobe pneumonias or abscesses, and you want to treat this with an antibiotic that covers anaerobes, and that's clindamycin. Pneumocystis jirovecii is an opportunistic infection in patients with AIDS or those who are immunosuppressed from transplant, organ transplant, and you prophylax and treat with TMP-SMX. And this is the kicker, is you gotta remember, when do you give steroids in a pneumocystis jirovecii infection? And you give steroids if the PaO2 is less than 70 or the AA gradient is greater than 35. And remember, in AIDS patients, you start giving prophylaxis for TMP-SMX at a CD4 less than 200. And also know how it presents, which is basically like an atypical pneumonia, which is fever, non-productive cough with bilateral interstitial infiltrates.